start. All right, guys. Hello. Good afternoon, everyone. I'm Alexis Sandor. I'm a fourth-year medical student at Ross University School of Medicine. I'm currently the secretary for CRG, and today I'll be presenting a study from JAMA Surgery Open Network titled Trends in Axillary Lymph Node Dissection After Mastectomy Among Patients with Limited Nodal Burden. And this study examines the shifting national patterns of managing lymph node involvement in breast cancer surgery. So here's just an overview of what I'll cover. I'll have an introduction into axillary surgery in breast cancer, the methods used in the study. I'll go over some key figures and results. Then I'll go through the discussion on, what they mean, and then finally, how it all applies to us clinically. So here's just a quick little photo and introduction of what the article looked like. I hope everyone got a chance to quickly skim it over. It's very interesting. So let's review the arterial supply of the breast. This is very important, obviously, when discussing mastectomy types and just surgical breast oncology in general. So I have a couple of covered up arteries. If you guys want to chime in, I can't see the chat, but if someone says anything in the chat, let me know. So the first one, let's go over the top left-hand corner. Does anyone know what that one is? You can unmute if you feel comfortable.
That's the axillary artery.
That is correct. Danielle, you got it. Future surgeon in the making. All right, guys. What about this one over on the far right-hand corner on the top?
Is it the internal thoracic?
Internal thoracic. Let's see. That's correct. Awesome job. All right. Going down. This one under the axillary artery. What is that one? Someone in the chat saying lateral thoracic. Let's see. That's correct. Lateral thoracic artery. And then this final one down here. I know you guys can do it. You've been killing it so far.
Is that just an intercostal?
It is a posterior intercostal artery. Great job. That was awesome, guys. All right. So I did just want to review the lymphatic drainage of the breast because it is very important, obviously, in breast oncology surgery. So there are three main groups. The axillary group is further divided into three levels. So level 1 is lateral to the lateral border of pectoralis minor. Level 2 is behind pectoralis minor. And then level 3 is medial to the medial border of pectoralis minor. So pec minor is kind of the main guiding of those three levels. And then we have the peristernal or the internal thoracic group and the posterior intercostal group, which unfortunately is not shown here. And the efferent lymphatics actually travel to the supraclavicular nodes and they terminate in the thoracic duct on the left. Obviously, this is a picture from the right. So the right end up traveling into the right lymphatic duct. So I also think it's very important to kind of understand the progression of breast cancer and to talk about the two most common types of breast cancer that we typically see. So the first most common type is the invasive ductal carcinoma. So this is an invasive breast cancer that starts in the milk ducts or the tubes that carry milk from the lobules to the nipple. It's the most common type of breast cancer. So about 80% of all breast cancers are invasive ductal carcinomas. The next type is invasive lobular carcinoma, another invasive type of breast cancer, but it actually starts in the lobules or the glands in the breast that produce milk. And it's the second most common type of breast cancer. So about 10% of all invasive breast cancers are invasive lobular carcinomas. And then we can see from benign to malignant here. So in situ basically means the cancer cells are still inside the duct wall. So there's no invasion that we see. They're kind of contained within that wall itself. When a cancer becomes invasive, it actually breaks through that wall, as we can see here on that middle photo. And then obviously when it gets metastatic, it travels to other parts of the body through blood or lymphatics. So before diving into axillary treatment, let's just revisit the different types of mastectomy. So there's a simple or total mastectomy, which removes all breast tissue, nipple, areola, and some overlying skin. The skin sparing, which preserves as much healthy skin as possible. And this is the type that I've been seeing the most commonly. I'm currently on a breast surgery rotation, and it's ideal for reconstruction, which a lot of women tend to decide to do. There's also a nipple-sparing mastectomy, which preserves the nipple and areola, and often the incisions are along the folds of the breast to allow for that preservation. There's a modified radical mastectomy, which removes breast tissue and axillary lymph nodes. And then there's a radical mastectomy. So that removes all of the breast tissue, but it also includes removal of the chest wall muscle. It's rarely used today. It's really more reserved for very extensive disease. And obviously, the type of mastectomy that is done influences the axillary management decisions moving forward. So this is just a photo of a radical mastectomy. So you can see here in this circled on the right side, they are taking part of the chest wall there in the muscle. So sentinel lymph node biopsy versus axillary lymph node dissection. So a sentinel lymph node biopsy is a less invasive technique to identify the first node that is likely to contain cancer. So it reduces the need for full axillary lymph node dissection when it's negative. This method has actually helped reduce significant surgical morbidity and actually helps stage cancer more precisely. On the other hand, axillary lymph node dissection removes all the lymph nodes in the axilla, and it's historically routine with mastectomy, or at least it was. And it's indicated for clinically involved lymph nodes or reoccurrence. However, it unfortunately carries a significant morbidity, and most notably due to lymphedema. So this is just an image of how sentinel lymph node biopsies or an axillary lymph node dissection is done. So typically before any surgery, a radioactive seed localization is done, and that is when they put a small radioactive seed placed into the breast at the location of the cancer or area concern, especially if like a lesion is not palpable. So in the OR, the surgeon will use a neoprobe to locate the lesion to know exactly where to excise. And the way that works is through the probe detecting gamma particles that are emitted from radioactive isotopes from that seed within the body. And that just allows for precise localization of the tissue. And then another useful tool that specifically helps to locate lymph nodes in the OR is the injection of isosulfane blue. So this is injected under the nipple or at the lesion toward the axilla, and then it's massaged for 5 minutes, to get the dye to move into the lymphatics. So its specific chemical structure actually allows it to be retained in the lymphatics. And a good thing to note is it's important to tell your anesthesiologist before injecting isosulfane blue, just because it can cause a drop in pulse ox readings, just momentarily. So from what I've seen on my rotation so far, we usually do a little mini timeout before injecting, just so everyone's on the same page and nothing bad happens. So as you can see in this photo, sorry, it is kind of graphic. The one on the top right kind of shows exactly them injecting the dye or the radioactive substance into the tumor. From what I've seen, we use both just because we'll say, you know, if the node is lighting up, it'll be hot and then blue. So you can see here on the left-sided image, the stained lymph node, it's kind of blue. Sometimes it's a little hard to see. And sometimes it doesn't get taken up as well in some people. It's just kind of luck of the draw. But usually I've seen a lot of the lymph nodes actually be hot and blue, which is great. All right. So post-mastectomy radiotherapy. So according to the National Cancer Center Network guidelines, radiation is recommended for patients with 4 or more positive lymph nodes. However, usage in patients with fewer nodes is actually increasing. So post-mastectomy radiotherapy improves local control and survival, but it is not without toxicity risks. And we can see this image to the right is actually showing planning for radiotherapy in a post-mastectomy patient. So a large meta-analysis by the Early Breast Cancer Trialists collaborative group pulled data from 22 randomized trials and showed that in patients with 4 or more positive lymph nodes, post-mastectomy radiotherapy actually reduced locoregional recurrence by 19%. and then breast cancer mortality by 9%. And notably, the Danish collaborative trials, which is the largest studies within that analysis, they demonstrated a 10% improvement in disease-free and overall survival with post-mastectomy radiotherapy in high-risk patients, regardless of tumor size or nodal burden. So as I mentioned, radiation obviously can have some complications. So you can see acute toxicities, and that just includes fatigue, sore throat, and radiation dermatitis is the most common. And people say it's very similar to a very severe sunburn. And then chronic toxicities can include involvement of chest wall fibrosis, hyperpigmentation, lymphedema, and rarely radiation pneumonitis, rib fracture, radiation-induced heart disease if you're treating the left side, and hypothyroidism if you are treating above the supraclavicular area. Interestingly enough, though, there is a very, very low risk of secondary malignancy following radiotherapy. Okay, so I know that was like a lot of review. Let's actually get into the study itself. So this study specifically wanted to take a look at what proportion of patients with breast cancer and node-positive disease undergo axillary lymph node dissection, and has this proportion changed over time? So in 2012 to 2021, axillary lymph node dissection use actually declined. So from 47.1% to 17.6%. And post-mastectomy radiotherapy actually increased from 9.8 to 36.8%. Yet, nearly 20% of patients still receive both. So this is a substantial proportion, and it raises concerns about possible overtreatment and its consequences, such as morbidity. So the methods of this study. This specifically is a retrospective cohort study, and they used the National Cancer Database and followed Strobe guidelines. So they included women who were 18 or older with clinically T1 to T2, N0, M0 invasive breast cancer. So they had 1 to 2 positive lymph nodes. They underwent mastectomy with surgical axillary staging. And they were excluded if they received neoadjuvant therapy, care outside of reporting hospitals, or were missing data on pathologic nodal staging. So they subsequently split these patients into 4 groups. So those who received axillary lymph node dissection only, those who received post-mastectomy radiotherapy only, those who received both, and those who received neither. They also examined tumor receptor status. So this was based on estrogen receptor, progesterone receptor, or ERBB2 receptor status, otherwise known as HER2 status. In addition, they also mentioned hormone receptor positive disease. So that was just defined as estrogen receptor positive and or progesterone receptor positive tumors. They also looked at facility volume. So this was defined as the mean number of patients with breast cancer a facility had reported annually. And patient race and ethnicity were actually captured through the National Cancer Database, and it was self-reported information. So treatment differences were assessed with a chi-square and an ANOVA. They used mixed effect logistic regression, and it helped them identify trends in treatment variability across facilities. However, due to a very low intra-facility correlation, the model was adjusted without mixed effects as the main analysis. No adjustments were made from multiple comparisons, and p-values from the 2-sided tests and results were deemed statistically significant if the p-value was less than 0.05. So the overarching question here is, are patients with limited nodal burden being overtreated? So let's talk about the data. So this is figure 1, and it shows basically that declining axillary lymph node, there's a decline in axillary lymph node dissection and an increase in post-mastectomy radiotherapy. So the biggest takeaway from this figure is that for patients with pathologic nodal 1 micrometastasis, the percentage of patients receiving axillary lymph node dissection alone decreased from 36.9 to 14%, while the percentage of patients receiving post-mastectomy radiotherapy alone had increased from 11.6 to 29.4 from 2012 to 2021. All right. And these are figure 2 and 3. These are the mixed logistical regressions. They are not very user-friendly to see, obviously, on a slide. So hopefully you guys can see it here. I know it's pretty small. So I'm just going to quickly run through what is important about this. So figure 2 specifically compared factors, compared predictors for axillary lymph node dissection versus post-mastectomy radiotherapy. And these factors included age, tumor subtype, and facility use. So you had a higher odds of receiving axillary lymph node dissection versus post-mastectomy radiotherapy if you were of older age, of non-Hispanic, Black, or Hispanic descent, had treatment at an academic center or a high volume facility, or had insurance with Medicaid or Medicare. You had a lower odds of receiving axillary lymph node dissection if you had lobular histology, had hormone receptor positive tumors, had lymphovascular invasion, had minimal nodal involvement. Additionally, interestingly enough, patients that were treated in the Western United States or in areas with higher education levels had lower odds of receiving an axillary lymph node dissection. And also those who had other forms of government insurance, such as private insurance, actually had lower odds as well. So figure 3 here, this one compares dual treatments to all other strategies. So again, facility practice actually played a major role here. So there was higher odds of receiving both axillary lymph node dissection and post-mastectomy radiotherapy in younger patients, non-Hispanic Asian, and non-Hispanic Black patients. Larger or more advanced tumors, such as clinically T2 or pathologic T3. If you had a higher grade tumor, such as grade 2 or 3, if you had the presence of lymphovascular invasion, if you had treatment at a Midwest or high volume facility, or if you had other government insurance versus private. You had a lower odds of receiving both therapies if you had micrometastasis, or if you had treatment in the South or the West versus in the Northeast. So the main takeaway of this figure is that if you had an aggressive tumor feature, you appropriately had more intensive treatment. And interestingly, socio-demographic and geologic disparities suggest that there's potential inequalities and variation in clinical practices here. So let's discuss some key points. So de-escalation trend. So in the US, there's obviously a clear shift from axillary lymph node dissection toward an increased use of post-mastectomy radiotherapy alone for patients with limited nodal burden. And this is actually consistent with global trends and the influence of the American College of Surgical Oncology group Z0011 trial. Unfortunately, overtreatment still persists. So despite this shift, approximately 20% of patients are still receiving both axillary lymph node dissection and post-mastectomy radiotherapy, particularly in the US. And that's compared to much lower rates in countries like the Netherlands. So that still suggests ongoing overtreatment. And there's some important drivers of dual treatment. So that's both axillary lymph node dissection and post-mastectomy radiotherapy. Younger age, aggressive tumor features, and certain institutional practices contribute to increased use of both treatments despite limited evidence of the benefit from dual therapy. There is key evidence already against axillary lymph node dissection. So the CENEMAC trial actually found no added benefit of axillary lymph node dissection in reducing reoccurrence or death, even in high-risk subgroups. And this is supporting the omission of axillary lymph node dissection when post-mastectomy radiotherapy is already planned. Modifiable practice patterns. So most dual treatments occurred when intraoperative frozen sections prompted immediate axillary lymph node dissection. So deferring axillary lymph node dissection decisions until after final pathology could actually significantly reduce overtreatment and healthcare costs. I see this very commonly in my rotation now where, we send frozen samples in the OR and we wait until they come back and, have we got everything or no? So this is kind of proposing, hey, maybe we wait until final pathology comes back, and that could potentially reduce costs and overtreatment. And then systemic barriers. So US practice variation may be influenced by fee-for-service models, fear of litigation, and delayed integration of trial data into national guidelines. And this is unlike countries with centralized healthcare systems where they already have the guidelines, integrated into their system. So the clinical correlation here. Clinically, we should obviously embrace evidence supporting axillary lymph node dissection omission for 1 to 2 positive lymph node positive patients. I think it's important to understand that post-mastectomy radiotherapy alone is often sufficient. And I think it's also very important to focus on how patient-centered and multidisciplinary decisions play a huge role. So as future surgeons, our goal should obviously be to provide effective care with minimal harm. That's the Hippocratic Oath for every physician, right? And I was once told by a preceptor, while being in the OR is fun, and that's the reason we go into a surgical specialty, one of the most parts of being a good surgeon is to know when to not operate. So that stuck with me throughout all of my rotations, and just something I wanted to share with you guys as well. The dreaded AMBOSS questions. I only have 2, guys, so I promise it'll go by as quick as we can. So I will read through this for you guys, and then you can answer in the chat what you think the answer is. So, an otherwise healthy 43-year-old woman comes to the physician 2 weeks after she felt a lump in her right breast. The lesion is not painful and has not increased in size since she first noticed it. Her menses occur at regular 28-day intervals. Her last menstrual period was 2 weeks ago. Medical history is unremarkable. Her maternal grandmother underwent a modified radical mastectomy for breast cancer at the age of 73 years. She drinks 3 to 4 glasses of wine on weekends and does not smoke cigarettes. Her temperature is 98.6 degrees Fahrenheit, pulse is 76, respirations are 14, and blood pressure is 126/74. Examination of the breasts show no skin or nipple changes. A firm, non-tender 0.5 centimeter mass is palpated in the outer upper quadrant of the right breast. There's no lymphadenopathy, and the remainder of the exam shows no abnormalities. Mammogram shows heterogeneous dense breast tissue. No focal lesion is found. What is the most appropriate next step in management? You guys can answer in the chat if you're comfortable, or if you want to use your mic, that's fine too. Looks like we have I see one answer in the chat saying E. So we're thinking perform ultrasound of the breast. We got some mixed answers here. I'll give you guys a couple more seconds. Anyone else want to give it a go? We have a mix of E, B, and D. But most are saying E. All right, I will go on. So those who said E, you are actually correct. So mammography is first-line imaging for patients who are over 30 years old with a palpable breast mass. Ultrasound is indicated for all patients with indeterminate results on mammography. And findings that indicate malignancy include hypoechoic or spiculated masses with ill-defined borders and posterior acoustic shadowing. So patients with such ultrasound findings should then undergo a fine needle aspiration or a core needle biopsy. Patients who are younger than 30 and have a palpable breast mass and findings on clinical assessment that will indicate, high probability of malignancy, and that can include, positive family history of breast cancer, skin changes, lymphadenopathy, fixation of the mass specifically to the skin or chest wall, nipple retraction, breast asymmetry. So if you're under 30, ultrasound is the first-line imaging modality, just because when you're younger, you have a relatively higher density of breast tissue. And that often makes mammography inconclusive because it's harder to see. So patients under 30 years old with a palpable breast mass and low probability of malignancy on clinical assessment can just have repeat breast exams 3 to 5 days after the onset of menses, because benign masses typically change in size during menstrual periods. So that's also something that's really important to keep in mind. Okay, guys, I have one more question for you. These breast ones are pretty long, so I'm sorry these vignettes are long. So a 47-year-old woman comes to the physician for a mass in her left breast that she noticed 2 days ago during breast self-examination. She has hypothyroidism treated with levothyroxine. There is no family history of breast cancer. Examination shows a large, moderately ptoic breasts. A mass in her left breast is small, approximately 1 centimeter by 0.5 centimeters. It's firm, mobile, and painless. It is located 4 centimeters from her nipple areolar complex at the 7 o'clock position. That is super important in breast surgery rotations. They want to know where things are. So important when you're describing things on physical exam for that. There are no changes in the skin or nipple, and there is no palpable axillary adenopathy. No masses are palpable in her right breast. A urine pregnancy test is negative, and mammogram shows a soft tissue mass with poorly defined margins. Core needle biopsy confirms a low-grade infiltrating ductal carcinoma. Remember, that's the most common type. The pathological specimen is positive for estrogen receptors, but negative for progesterone and human epidermal growth factor receptor 2, otherwise known as HER2 or ERBB2 receptors. Staging shows no distant metastatic disease. Which of the following is the most appropriate next step in management? So would we go right to a mastectomy, or would we do a lumpectomy first for this breast mass that we found? This one's pretty hard, I won't lie. I picked a difficult one. Okay, I'm seeing a majority go for lumpectomy. Looks like there's a little rift between C and E. So we're unsure if we should do radiation or not. I can't lie, when I did this one the first time, I did not get it right. Looks like we got like 3 or 4 for E, 2 or 3 for C. All right, guys. So if you picked E, you're right. Treatment for early stage invasive breast cancer involves breast conserving surgery, which is considered lumpectomy, sentinel lymph node biopsy, which we talked about, as well as adjuvant radiation therapy, which is radiotherapy. So sentinel lymph node biopsy is necessary, obviously, for cancer staging, and that determines subsequent treatment. So all patients who undergo breast conserving surgery, such as lumpectomy, will require adjuvant radiation therapy just to minimize the risks of reoccurrence. Given that this patient has a hormone receptor positive cancer, she can also receive adjuvant endocrine therapy with tamoxifen or an aromatase inhibitor. So yeah. Good job, guys. So that is all for me. Just want to thank everyone for their time, and say how grateful I am to my mentors and peers who supported me through making this, and I'd be happy to take any questions you guys have. And this is just my resources. You guys can come off mute if you have any questions. Or you can throw them in the chat, whatever you prefer.
Well, if no one has any questions, I just want to say
Hey,
presentation. Oh, sorry. Go
sorry, I didn't mean to cut you off. My internet is about to cut off, but I just wanted to say it was a really great presentation. It was a great review because I'm about to write step 2. I was like, breast stuff is just wild, but one of the hardest questions to get through. Really great presentation, Alexis. Thank you so much. And it goes really well with the trial that I mentioned like before. We had a member who presented about the more hormonal treatment of breast cancer a while ago. And this presentation goes really well with the Z trial, Z001, about doing like axillary dissection. And the study kind of goes well with the findings of that study. So I just wanted to mention that quickly before my internet cuts off.
Thank you so much, Julia. Yeah, that is this specific study had mentioned that trial. And it's great, a great parallel to it. I think they go hand in hand for sure.
Awesome. Anyone else have any questions? All right, well, oh, go ahead. Nina.
Sorry, really
you're-
great presentation, Alexis. Just a question, how long are these patients being monitored for? Like, do they have to do mammograms every year, or how does it work?
That's a great question. This specific study didn't mention it, just because the National Cancer Database didn't include that in the findings. So from what I've seen, it really depends on how extensive the disease is. So if you've gone through, a mastectomy and then you did radiotherapy and you also did neoadjuvant chemo, I've seen like once you complete that all, you meet with the breast surgeon again and the oncologist, the medical oncologist, and kind of decide, when can you start doing just annual mammograms again. So usually it's like after all of the treatment has been worked through, if you're doing all like triple treatment, and then you can kind of just go back to your annual screening mammograms. Sometimes they want to watch every 6 months, depending on what kind, or if you have like a very high risk. But sometimes patients with high risk will actually undergo risk reduction mastectomy just to kind of completely, eliminate the possibility of having breast cancer come up in any time in their life. So that's a great question, something I'd have to definitely follow up on.
Gotcha. Thank you so much.
Any other questions? All right, I thought I'd give a longer pause this time. All right, thank you so much, Alexis, for that awesome presentation. So I guess we'll go into our housekeeping stuff now. I think we can stop recording, right? Is that how it goes?
I think you are right. I will do that. There we go.